a very uncommon presentation of a common disease. So I thought of sharing this with you because you see, if you follow the normal dictum that how to investigate, you see, in all my videos I have been telling history and examination. But if you follow that rule, basic, you will not miss even the uncommon presentations. The example is today. This was a child. Now the child came to us 2 months of age. But I go back to the previous history. This child was born here, full-term delivery, 1.5 kg. Child had meconium aspiration. Because of this meconium aspiration, this child was kept in the nursery. Now, since the child was kept there, IV fluids were given, and I think the feeds were also started on about 5th, 6th day, what I gathered from the records. This child, even there also, during the antenatal history, it was normal. I also asked, the ultrasonography was done 3 times in the prenatal period, and this was normal. There was nothing was found in the newborn. Now, when the child was there in the nursery, some tests were carried out. That is mainly the torch group of infections. The mother and child, they were negative for torch. The child was found to be little bloated. There they found that the child has got edematous. But then it was brushed aside, keeping in mind that this child has got the child has been on prolonged IV, so maybe the hyperproteinemia must be there, and that is why the child has got edema. And so much so that the child received in the nursery 3 albumin transfusions. Right? So this all happened here. Now, having stayed there, the child was discharged, the child was managed accordingly, kept with a diagnosis of sepsis with meconium aspiration syndrome, and child stayed here in the nursery for about 21 days. Now, having said that, the child was discharged on the supportive care. Child stayed at home for a month. There was no problem. Child was getting feeds well. I did ask the mother. The breastfeeds were being taken. Child was passing urine adequately. So absolutely everything was fine. Now, one day, this child, when the child was being fed by the mother, this child had some choking spell. Maybe there was some aspiration, or the child had that feelings, and the child got little cyanosed. So in that panic, they brought the child to the hospital. So when they brought the child to the hospital, at that time, it was just in October, 28th of October. So the child had, when we examined, now this is the question of examination. When we examined this child, maybe you see, at that time already the child had become 2 months of age. The child was found to be having periorbital puffiness. So child was found to be having abdominal distension. And as I said at the outset, go with the normal principles. So I just asked that why don't you go in for a urinary proteins of this child? And urinary protein of this child was 3+. So keeping that in mind, a possibility of this child is less than 3 months, possibility of a congenital nephrotic syndrome was kept. Not very common, but then it can be picked up much earlier also. If all the residents, as I always say in my videos, that you follow the normal dictum. When you had the edema, just after birth, maybe at that time somebody would have done the urinary protein. I think Manish must be there in the nursery. He never does anything. He was in the nursery. See, he say yes. So Manish, you see, I am trying to talk to you that the child urinary proteins were never done. So now this time we send the samples. I just tell you, when the child was, all the samples for nephrotic syndrome was sent. And at that time, now this time this child had, at that time when the 3 albumin infusions were given, the levels of albumin had also fallen down to about 0.62. And now at this time it was about 1.4 when the child came to us in the emergency. So though the child was passing normally, the urine output was okay, we got the other test done. I'll just read about the other test. There was, of course, there was examination, there was no organomegaly. There was, we can shoot that video here. Then I'll talk about the other investigations. Let's, isko upar hataiye. Just focus it up here. See the child. See the child. First of all, focus on the eyes. There is periorbital puffiness. There is abdominal distension. Can you see this? And even if you press it here for some time, even there is abdominal edema. There is abdominal edema, and if you cannot, you may not appreciate here. You see this? Focus it here, and this child has got pedal edema. See this? This child has got pedal edema, even though I did not press it for 30 seconds, which is a normal dictum. So the child has got generalized anasarca even at the age of 2 months. And somehow, as I always say, if you had examined it much earlier, before giving 3 transfusions albumin, maybe you would have picked it up, maybe. Yes, we were lucky that the child was presenting with the gross features of edema. Maybe at that time there were no gross features of edema. So I don't say anything about it, but I am telling you urinary proteins should have been done. If you find before giving albumin infusions and keeping everything, then maybe it is a prolonged IV. You do give IV for prolonged periods, but you don't get generalized edema in most of the newborns. Am I right? You've seen the video. I've tried to focus the abdominal distension, generalized anasarca was there. Now I tell you, since we thought of a nephrotic syndrome, then we did some investigations. First of all, let's talk of this child was 1.5 kg. Going by the examination, before the investigation, the child weight was at that time was about 3.2 kg. Today also we have weighed. It is 3.2 kgs. Length is 50 centimeters and head circumference is 35.5 centimeters. So the child is, at present the child of course from the birth has improved in weight and in the length. I think earlier the head circumference was 32.2 and now it is 35.5 centimeters. So everything is going as per the age. Now talking about the investigations, the serum albumin, as I said, it was 1.5 gram per deciliter. Cholesterol was 347 milligram per deciliter. The electrolytes were normal. CBC was normal. Complete blood count was normal. The creat and urea creatinine was done because kidney functions were done. Kidney functions also within normal limits. I think the serum creat was about 0.3. Right. The ultrasound of abdomen was done because the child had distension. So ultrasound of the abdomen said clearly revealed mild to moderate ascites with normal sized kidneys. So this is what happened in this child, right? LFTs were normal. Yes, one thing, as I always say, you always tend to gain, and I am honest in saying that I also didn't know that in congenital nephrotic syndrome there could be a picture of hypothyroidism. So we never sent at the outset, but now today we have sent that you, because of the thyroid binding proteins, they release in the urine, and because of the release of that urine, sometimes even in the normal nephrotic syndrome also you can have a hypothyroidism. So since there is absolutely too much of albuminuria, you must get the TSH and the free T4, so which has been sent today for the ruling out hypothyroidism. Right. Now this is a case which fits into a genetic nephrotic, the congenital nephrotic syndrome. I'll briefly tell about the congenital nephrotic syndrome. Congenital nephrotic syndrome is most of the time is genetic. Now, if you say it can be divided into less than 3 months, between 3 to 12 months. If it is less than 3 months, it is most probably it is genetic in nature. Now, genetic defects have been found to be 4 types. One is called NPHS1 mutation. That is a nephrin mutation, and there it occurs within the first 3 months. Then there is something called as NPHS2 mutation, which is if podocytes get affected, podocin is there affected, and that occurs usually after 3 months. So 3 months to 12 months. The third one, which is a very important genetic mutation, is the WT1. And WT1 we used to ask for, even if you have a child of Wilms tumor, then you have that mutation. So that could be under that. One more thing is important is, whenever you have a child of congenital nephrotic syndrome, you must try to look for the genitals. I didn't look for the genital. There is a swelling of the labia majora, but there is no disorders of the sexual development. Now why I am saying is because if it is WT1 mutation, then there is a triad. This is called Danny-Drash syndrome. In Danny-Drash syndrome, you have disorders of the sexual development. You have much more predilection for Wilms tumor, and the third one, of course, is your congenital nephrotic syndrome. So if a child comes to us with congenital nephrotic syndrome, you have to get the genetic analysis done. So the fourth mutation is called as the LAM2 mutation. So these are the 4 mutations. But why they are important is, if the child is less than 3 months of age, as this child is, which I am showing to you, this child most likely, because it is important. Now how, first of all, is the diagnosis, then you have to find out the treatment or the management. Now question is, in my time I still remember the genetic analysis was not that elaborate. So we used to do, I still remember 2-3 cases only I would have seen in the whole career, that we had done the kidney biopsy. Kidney biopsy in this child, I talked to my nephrology colleague, and he also said, sir, nowadays kidney biopsy has gone into the little background, you may have to talk about the genetic analysis. So genetic analysis we have already sent. Then what are the indications for kidney biopsy? If you find there is a history of, it's non-genetic in nature, you don't find any cause, then maybe at that time and you don't find any secondary cause. Others, what could be the other secondary cause? One could be that the mother is suffering from mother is having some torch infection, or mother is having some maternal lupus. If maternal lupus is there, the child may be born with congenital nephrotic syndrome. But that usually occurs after 3 months, that is from 3 to 12 months of age. Right? So kidney biopsy will be going into the background. I have already sent the sample for the genetic analysis. Sample report will come. I'll talk to you later about the analysis report. After about 21 days, I think we'll get this report. And if it is supposing one of the mutations is there, and especially I find NPHS1 mutation, then the prognosis, of course, then what is the treatment? Now question is about the treatment. Now question is that treatment in genetic congenital nephrotic syndrome, you cannot give steroids. They are steroid resistant. Even immunosuppressants also they don't require. It can't be given. Yes, but if the child has got mutation which is NPHS2, that is podocin, podocytes are getting affected, then sometimes even immunosuppressions might work. They might improve sometime even with steroid or with the immunosuppression. So that's very important. So genetic analysis we are getting it done. Then we will get put the patient on accordingly. Now what is to be done for this congenital nephrotic syndrome if it is presenting within 3 months? What are the therapeutic options? Anybody? Zaragesh, you are nodding your head. So I think you have read about congenital nephrotic syndrome. So tell me something about congenital nephrotic syndrome. Now the treatment modalities.
Albumin infusion.
Yes, albumin infusion is a hallmark. One is albumin infusion. Now there are 2 things, as he rightly said. Albumin infusion, when I was going through the literature, albumin infusion also there are 2 divided thought. One is, if the child, you have to clinically see the child, or you have to biochemically monitor the serum albumin. If supposing the child urinary output is okay, luckily you see in congenital nephrotic syndrome, the phenotypic variation can be much varied. They can start at the outset with the problems of the nephrotic, gross edema, and they can go in for kidney failure. The other thing is, luckily for this child, the child phenotypic manifestations are not many. But yes, the child is little bloated, child has got low albumin. But then when I was looking at the literature, if you have the good amount of urinary output is there, I inquire the mother, urinary output is okay, only thing is that the child has got generalized anasarca, there is no distress, you see, we should also go in for the effusions. X-ray chest of this child is normal, but then as a marker we must go in for an echocardiography, we must go in for to find out whether there is any pericardial effusion or is there any pleural effusion. Yes, had it been there, child would have been much sicker or maybe had been having some respiratory distress. But what I am trying to say, now based on the clinical criteria, this child does not require routine albumin infusions. But then there is one school of thought that if the albumin is low, then you have to monitor it. Even some people have advised giving it at home in the West. Of course, not possible here, but in the West they say that the output, the mothers or the parents can even give it at home, or paramedics can come at home and give it the albumin infusion. But yes, keeping all things in mind, what I was reading about, the concession statement says that you should clinically monitor. So what I am trying to talk about this child is that we will be not giving as per the values of the albumin. But yes, if the child has got decrease in the urinary output, swelling has increased too much, we are monitoring every month the renal function test, and if the renal function, if there is a renal insufficiency signs are there, then maybe we have to resort to giving albumin. Because you see, what will happen? Albumin, if it is not there, then the signs of hypovolemia. The child is going for shock. So you have to clinically monitor that the normovolemia is there. Yes, during the episodes of any, you see, these are the children who are more prone to have infections and thrombosis. So you have to keep those things in mind. Usually it is not to be started the prophylactic antibiotics, but even if there is some evidence of infection, you should start the antibiotics very fast. So you see, what happens is they pass so much of, there is hypogammaglobulinemia, so what happens is there is immunity is depressed. So any infection, any time, you should start the antibiotics very much faster. Now what are the other treatment options is, I've talked in detail about the albumin. So I have decided that we will be giving it as per they will be calling them and monitoring the patient. And if the clinically, as I said, if clinical parameters will be kept in mind, because most of the theories or most of the workers are in favor of, yes, of course, we will do the management along with the nephrologist, pediatric nephrologist I have been talking to. And when the child gets older, then you need to have a proper diet of this child. A renal dietitian or a dietitian needs to be consulted. They need to be given little less of fluids, high protein content, high calorie content, but less of salt. So this is what is to be kept in mind. Usually the other drugs which are to be kept in mind is depending on the edema, as we go in for other nephrotic syndrome, the diuretics. Diuretics maybe initially, if there is a signs of hypervolemia are there, so much of loss is there, the distress is there, edema, ascites is too much. So if there is too much of the stress is there, then we may have to give the injectable or the oral diuretics. The last important thing is, which I was thinking of giving to this child, is the RAS inhibitors. That is renin, angiotensin, aldosterone system. So they are what are they? They are ACE inhibitors. So ACE inhibitors you can give, or you can give ARBs. That is angiotensin.
Receptor blocker.
Which blocker? Receptor blocker. ये तो तुम्हें आता है. So angiotensin receptor blocker. So like losartan, right? So the short acting ACE inhibitor which can help in this child is the captopril. That is the shortest of acting. Then you have rimapril or other drugs which are larger acting. But then the risk for that is, how does it help in such patients? Why it is important to start in these children, they should not be given less than 4 weeks, but after 4 weeks you should be giving them. Why? Because proteinuria gets impeded. If there is a decrease in the proteinuria, there is less of toxicity to the kidneys. So that is why you have been giving the captopril. So maybe I will have to start this child on captopril. Look for, because there is a risk of hypovolemia occurring in these children once you start these patients on captopril. So call them frequently. Luckily they stay very close to the hospital, so they can come. And so captopril is one drug, so RAS inhibitors is the other way. Now question is, not in this child, but I must tell you the whole scenario, that as I said, some children behave in a very severe fashion. What do you need to do that? There you do the nephrectomies. And nephrectomy needs to be done because there is excessive, you have to be giving albumin every day. So phenotypically that severity also can occur. So there you do the nephrectomy, and then following that you do the dialysis and close to the renal transplant. So the renal transplant needs to be done in such patients who are very severe. So you have to personalize. In this child it is not very severe, but we have to follow it up. And usually the renal transplantation, if they do, very excellent. If there is no evidence of infection, there is no evidence of any thrombosis, then they do very well. So that is all today. That had how a common disease, because we usually don't suspect. First of all, the incidence is also very less. But then, as I said at the outset, if there is so much of edema, even in a small child, go at least for a urinary protein. It's not a very simple, it's a simple investigation, bedside investigation. Had you got it earlier, you would have picked it up. The earlier you pick it up, the prognosis is much better. That's all. Thank you.